only ever medical in San Diego. The difference between LA and Sacramento, quite honestly, or at least a couple of years ago when we looked, was that LA has a preponderance of dentists willing to take DentaCal. We don't. They also have a bunch of community clinics, which we did not. We now have many more, which we're grateful for. And when given a choice, because the kids in LA get to choose, 15% of the families do, in fact, choose a managed dental plan, but 85% don't. So when Sacramento County was encouraged to be the pilot, and let me comment on the word pilot because it sort of drives me nuts. This is a mature program. This is not a pilot program. The department can't tell you that it's not a pilot because in doing so, they acknowledge that as a mature program, one could legitimately ask, upon what basis have you determined it's no longer a pilot? Show us the documentation and the evaluation, and we know there is not any. So, of course, the goal was to save money because if instead of paying 100%, you lop off 5%, you've saved money. But we asked for whom. It was also, of course, legitimately to see if members got better access to care, but nobody checked. So just a review of the utilization findings, because that's really probably the most egregious, and that's what caught people's attention. The 2008 data, and I will tell you because people have commented on, gee, it was really hard to get data from the department. Well, you almost have to be a little terrier pulling at their cuffs every day. And I darkened their door for probably 6 months and had at least 34 different data requests and dogged them until we sort of got it. And even then, there's discrepancy between what the plans told us they gave the department and what the department produced as official data after it went through the machinery. Anyway, in 2008, you've heard, and these are the 0 to 20s. In a minute, I'm going to talk about, or I'll focus on the 0 to 6, 0 to 8. 1 out of 5 kids had a dental service. It's improved, but only about 1.5 out of 5 kids now had a dental visit in the most recent period. So we're encouraged, but it's still behind state rates. When we look at breakdowns by age, you'll see, of course, that the 4 and 5-year-old group and, of course, the 6 and 8-year-old group are always going to be higher because of the law that requires a kid to have to see a dentist by kindergarten. So naturally, we see that. And this is really just to show you not only disparity in age, but improvement over time. This is a comparison of the GMC rate with the fee-for-service rate. And again, showing you there's pretty much no difference when you're talking about the older age group of this age range. But there still, of course, is with the 0 to 3. And then the last sort of statistical graphic that I'll show you is by plan, because I think this is kind of interesting. You'll notice who the better performers are. In this particular slide, you'll see that what should have been yellow but looks sort of pea soup green here is Liberty Dental, and you'll see on the other end Community Dental. That's the darker purple by each of the age ranges. And so I don't have a slide of this, but in our report, the average, and this was 0 to 20, utilization across plans range from about 5 to 6% at Community Dental to 34% Liberty. Very quickly, other key findings. When we looked at quality of care indicators, what we used were ratios. Well, obviously, if you're not providing a service, you're going to have very low ratios. So compared to the, we used a fee-for-service county, Fresno, because of similar demographics and so forth, and found that in that fee-for-service system, much higher prevention to treatment ratios. In terms of access, we've talked about dentistry and dental workforce because that's what this committee is interested in as well. I'm not sure I heard this number, so I'll mention it, possibly being redundant, but there are about 1,100 something dentists in Sacramento County that are active, 80% of whom are general dentists. we have an adequate number of bodies. So the body count is not necessarily the problem. The problem is willingness to participate in Medi-Cal dental, for all kinds of reasons. But we have to understand, and I'll comment a little more about this in a minute, fee-for-service is not the panacea. So for people to say, just, chop off GMC, get rid of it, go to fee-for-service, problem solved, not, unfortunately. The Medi-Cal dental program did not save money, as it turned out, in the year or two that we looked at their data. We expected to see it. They probably did too. It didn't happen. The bullet point number 2 is extremely important for 2 reasons. At that time, Medi-Cal was still covering adults. They quit maybe about midway through 2008. The provision that had been in the contract was 38% utilization threshold before a penalty was levied, but it was for kids and adults. It never differentiated between the two. And so if you saw 60, 70, 80% of adults and 10% of kids, you could still meet the threshold. Very important. Second important thing, we were told confidentially by a state staff person that there was a general person's agreement between the department and the plans to not enforce that contract provision because they didn't want the plans to drop out. The department has very inadequate staff capacity to monitor these programs, both in terms of number and in terms of, I'm not implying competence, type of staffing. They don't have adequate numbers to begin with. They don't have adequate numbers of dental professionals. And those who do are focused on the fee-for-service side. I mean, admittedly, that's the big service model in the state, but nonetheless. When we talk to Department of Managed Health Care to see, what is your role in all of this, it was very interesting because the comment to me, we had 2 meetings. The first, when we're asked to meet with the sort of lower level staff, and one of those persons said, we only focus on the commercial line of business in dentistry. And I said, wait a second, the Denti-Cal managed care plans are licensed under your, oversight. And later I got a memo from the attorney from that department clarifying, what we meant was, we actually do, when we're asked to, and yes, we coordinate with the state. I hope things have changed. When I mentioned briefly, other states' Medicaid managed care dental plans have implemented many more improvement strategies than California. They bumped up their rates. I mean, our rates are appalling. They were, at that time, the lowest in the nation. They probably still are. They have many more parent education programs and so forth, and that's certainly detailed in our report. So it's not hard to follow some of those successes if one wants to. We looked at various options and basically recommended to the Commission that they not scrap GMC, but that it could be made better. Patients have had positive experiences clearly in these plans, and they should be allowed to choose to continue there if they want. But they should also be able to choose in the fee-for-service system with the proviso that there's adequacy in that system. Having an insurance card in your wallet doesn't do you any good if you can't use it. There needs to be the culture of monitoring. I deliberately use that word culture because it has to be part and parcel of what a program does, not just financial monitoring. People actually have to step into the clinics, step into the dental practices, pull dental records, talk to patients. You can't monitor from an office in Sacramento. Very quickly, the required elements for success, and there are more, but these are sort of the obvious ones. It's not hard. You've got to have a dentist willing to participate in your network. You've got to pay them an equitable rate to do that. If you don't pay them an equitable rate, why would they want to participate? Expanded access through community clinics. Very pleased to see what's happening in Sacramento County. Need more of it. Clinics need direct access to the payment mechanism. They need to be paid more per patient than the cost of a McDonald's burger, if it's even that high. Paperwork that's less burdensome. I mean, I won't even go into that. Enforcement that's real. And lastly, parents that understand and value kids' oral health, because parents have a lot to overcome in their own barriers, and not, just the obvious ones, transportation, childcare, and so forth, but values and attitudes. And I will tell you, with somebody who has a master's in maternal child health nursing, I never even knew that you were supposed to take your kid to the dentist before they had teeth, like 3 years old. If people who are in the field and who have an education don't really get it and haven't been informed, I mean, think about all of the families that really don't have that information. I know you are very aware of the whole perinatal issue. You were on the advisory committee for the protocols that I helped produce. That's where it starts. It starts with the pregnant woman. She's a child, so vicious circle. But, clearly we have to understand that you're going to affect a child's oral health beginning when that child was conceived.
Well, thank you, Dr. David. Really appreciate this. I think it was a great summary to what we heard today. We are sort of, I think, running into the end of the time that we actually have the room. So, okay. So, but I want to again thank all our presenters, and thank you again for your presentations. It's been very, very informative, and something I think again we will be working with the other policy committees. I do serve on the health committee. I've had conversations with Chair Bill Monning, who's very interested in this issue, and so we hope to see continue action. We know that Senator Steinberg is taking leadership as well in terms of looking at legislation, and we had Assemblymember Dickinson here as well. So, as well as, of course, locally Supervisor Cerna as well. I hate to sort of cut off any public comment because we're sort of very short on time. I might, if there's someone who really has a burning thing to say and you can say it in 1 minute, I'll give you a chance to say it. So let's keep it very, 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 very brief. Yes. Yeah, sorry, I apologize. Okay.
I'm a doctor of the GMC provider.
Okay, all right. So actually, what you want to go first, and then we'll get.
Sure. My name is Tiffany Settle, and I am the practice manager of Kennedy Family Dentistry. My father is Dr. Kennedy. He has been participating in the general managed care plan since they started in 1993. When I graduated college and looked at his books, I told him he needed to eliminate the program altogether out of his office. He told me very sternly that was not going to happen. He is here to support his community. They are the community that helped him get through dental school. What I can tell you is that we are paid $2 to $4.50 per patient that is assigned to our office at no reimbursement or very little reimbursement. We are averaging $200,000 to $5,000 worth of work per patient that we see at any given time throughout the month. One of the biggest issues that we've got with managed care programs is one of the things that the parents had said with the referrals. What we see as a provider is the patient comes in, we see them, we treat them. There is no difference whether they're private or managed care. We are one of the few offices that facilitates that way. We are having a very difficult time with these GMC plans getting the referrals processed, approved, to where patients aren't waiting a year to have a tooth taken out, be seen at a pediatric office, and it makes it very challenging on our end to get adequate care for these patients when we've done everything that we can do in our office with no support from the GMC plan. So,
well, thank you. Thank you for your perspective. No. Right.
Hi, I'm Dr. Richard Nguyen from Zinfandel Dental Practice. I work with Liberty and HealthNet very well. We coordinate a lot of the pediatric kids that need the work. As you know, not all plans are created equal. When in 2005, Liberty came to me and asked me, well, we didn't have any pediatric dentists who was willing to take the care of the kids. So they bestowed on me to manage and try to take care of the kids as much as possible. For me, going to fee-for-service, the reason why I don't take fee-for-service is because of the problems with billing, having the headaches, like one of the pediatric dentists who says, well, she did it for 8 years. You know, we have to take pictures. If they say the cavity, I say think it's a cavity. They say it's not a cavity because it's a small cavity. It's not a big cavity, and I don't get paid. It's just gruesome. What happens is if you switch GMC and split GMC and fee-for-service, what happens is you're taking the patient's, the whole pie and shifting it over to the fee-for-service, and what happens, it's taking money out from the GMC plans, okay? If you take money from the GMC plans, all the good patients who don't need that, just needs cleanings, simple fillings, are going to go to fee-for-service, because the dentists who want to do those, they're going to have a feast because they're getting more money for less work. Whereas the ones who need the work are going to stay in the GMC system because they can't get specialists for fee-for-service. So what happens when you're putting the burden on the GMC, their cost goes up, but their reimbursements go down. What happens then? You're gonna see a lot of these plans like, to forget it. My margins are already low. Now you're telling me it's gonna go lower to the point where you're basically abolishing the GMC system. It's not that the GMC system is not working. It's because you have to find the plans that are actually making sure that they coordinate with the providers, because it's a three-part system for GMC. It has to be the plan, the provider, and the patient. If none of them, works together, basically you're going to get these problems no matter what, if it's fee-for-service or GMC.
Well, thank you. Thank you so much. And I think one of the big things we've emphasized is, and actually I do have to cut off time. We're just out of time. So, again, one of the big things we're going to be talking about is really, oversight, whether no matter what system and the results we need to get. So I want to, again, thank everyone for being here. If anyone else wants to have anything they want to share, actually, Paula can take your testimony and your notes. Okay. And I really, again, want to thank everyone for taking your time to be here today, and really appreciate all the presenters, again, for their willingness to present. Thank you so much.